Hello everyone, my name is Anna Pettit. I'm a UK registered dietitian and nutritionist with a specialism in food allergy, and I'm very pleased to present today a talk on food allergies, the complexities of presenting symptoms, the diagnosis and safe dietary care. I don't have any disclosures for this presentation, and the outline is as follows. So we're going to be looking at adverse reactions to food as an umbrella term for all food hypersensitivity reactions. We'll touch on food allergy and food intolerance and the main differences in pathophysiology of these two conditions. We're looking at the diagnosis of food allergies and why is it important to get the correct diagnosis. The big 8 food allergens, the food allergy test, and the considerations of safe dietary management. We'll also touch on EDS and why is it mega important to get the right diagnosis for the population with this condition. So to start, this slide illustrates a wide variety of adverse reactions to food. So adverse reactions to food are any untoward reaction after the food ingestion or ingestion of a food additive, and it can be broadly divided into immune-mediated and non-immune mediated. You also have toxic reactions. So toxic reactions can happen to anyone. This is your typical alpha toxins in peanuts, for example, or scombroid poisoning, whereas immune and non-immune mediated reactions are very individual. So immune-mediated reactions can be further distinguished into food allergy, which can be IgE mediated, so involving the antibodies called IgE, immunoglobulin E, non-IgE mediated, so involving other cells of the immune system, mixed reactions, so presenting with IgE and non-IgE symptoms. And also under the realm of the immune-mediated, you've got celiac disease, which is autoimmune condition and involves other cells of the immune system, not IgE. Under non-immune mediated, as you can see, there's food intolerance, and food intolerance can be split into pathophysiology explained reactions such as pharmacological reactions to caffeine, histamine, biogenic amines, enzyme deficiencies, either total or partial. So, for example, lactose or fructose malabsorption, and unexplained, so non-specific gut and non-gut reactions to food, such as those in the gut-brain interaction disorders, such as IBS, where there is visceral hypersensitivity or gut sensitivity to the stretch of the gut when certain foods are ingested, such as FODMAPs, which we will cover later on. So just to go over food intolerance, there is generally a huge misunderstanding, and the food intolerance and food allergy terms are used interchangeably, which creates a huge misunderstanding amongst general public and health professionals. So food intolerance affects the GI tract, so it doesn't affect the immune system and it's not mediated by immune cells. It usually happens, as I've mentioned in my previous slide, due to the lack of enzymes or our inability to digest certain foods or components of that food. It's usually dose dependent. So in example of a lactose intolerance, people with primary lactose intolerance can manage milk and tea and coffee, whereas if they were to drink a glass of milk, that's going to be more problematic. And usually the reactions are to carbohydrates, to food additives, to vasoactive amines, rather than proteins. The symptoms that are experienced usually are not only confined to the gut, although the gut system is involved. They also can be cardiovascular and respiratory, such as low blood pressure, flushing, runny nose, sneezing. And food intolerance can also be linked to irritable bowel syndrome. So, as I mentioned, a lot of people with IBS report sensitivity to particular foods which are highly fermentable, called FODMAPs. So those those carbohydrates, we don't have the ability to digest them because we don't hold the enzymes for some of the FODMAPs. So the bacteria in the gut actually does it for us. And as the fermentation happens, the gut distends, and the visceral gut sensitivity can cause a lot of pain and discomfort in those people. So how do we diagnose food intolerance? We know that up to date, we don't really have any evidence-based tests apart from a hydrogen breath test for lactose intolerance, which can be used in clinical setting. It's really easy to diagnose with what is called the 3R method. So you record everything you eat and drink and the symptoms you experience. You try to identify the culprit food that causes the symptoms, or perhaps several foods. And then you try to reintroduce that food or those foods one at a time to confirm that that food was actually the culprit in your symptoms. A word of warning: if you've excluded foods or multiple foods from your diet for a number of months and you're still continuing to have symptoms, it's unlikely that that food is the cause of your symptoms. So you need to bring it back. And I will explain why it is important in my next few slides. So with regards to IgE-mediated allergy, this reaction involves antibodies, particular antibodies called immunoglobulin E, which are made when a susceptible individual comes into contact with foods which are usually considered safe. So those antibodies are made, they attach themselves to the mast cells in the immune system, and when in the process called sensitization, so the person becomes sensitized or sensitive to that particular food. On repeated exposures, when the protein comes into contact with those particular antibodies, this causes mast cells to release a lot of chemicals, which can lead to your classical symptoms in allergic reactions, such as hives, swelling, tingling of the throat, tightness of the throat, persistent cough, difficulty in breathing, and so on and so forth. These type of symptoms can be mild, but they can also be severe. So in the case of anaphylaxis, for example, which is a severe life-threatening allergic reactions affecting airways, breathing, and circulation, it can be dangerous, so it has to be managed appropriately. Conventional allergy testing with skin prick test and specific IgE blood test can be helpful and can aid the diagnosis. But you do need a good allergy-focused history. You do need to record a few things in terms of the diet, what has caused the reaction, in what form, and we will cover that a bit later on. Food challenge remains the golden standard of the food allergy diagnosis. This is where the history or perhaps the allergy tests or both are not very conclusive. So we may want to bring the person into hospital under clinical supervision to reintroduce those foods. Non-IgE mediated is another type of allergy. It's not a food intolerance as often thought. Because it doesn't involve IgE, it's really hard to establish with tests. We don't have any tests for non-IgE allergy as of yet. So this reaction involves other cells of the immune system, and the signs and symptoms are usually of a slow onset. So they develop 2 hours and up to 72 hours after the food ingestion. Some of the symptoms you may experience are eczema flares, persistent gut symptoms such as reflux, and these can be mild, and in some non-IgE mediated allergies such as FPIES, food protein-induced enterocolitis syndrome, or eosinophilic esophagitis, EOE, these symptoms can lead to more severe symptoms such as dysphagia, reflux, food impaction, and profuse vomiting and diarrhea. So as I've mentioned, conventional allergy tests are not useful. Exclusion and reintroduction of the suspected culprit food can aid the diagnosis. And this is usually the case in infants with cow's milk allergy, but as I've mentioned, some of the forms of non-IgE allergy are more severe. So we may need to bring these people into hospital and introduce the foods under supervised conditions. So the cornerstone of food allergy diagnosis really lies within a very thorough allergy-focused history, which does also cover dietary history. So potential triggers are explored. This is really to ensure that the correct foods are being tested for. We don't blank test for multiple food allergies because the dangers are that a lot of people are sensitive to foods, but they don't really have any allergic reactions to them and they can continue to eat them. When you blank test someone, you can pick up on those sensitivities, and unfortunately that can lead to a lot of unnecessary restrictions. So you're looking at the age when symptoms are first started and the frequency. You're looking at family history, so family history of atopy or genetic predisposition to allergic disease. Hay fever, asthma, eczema diagnosis are very relevant. The exact foods eaten in what setting, were they cooked, were they raw, was it a composite meal or was it a food on its own? Also, some of the things called cofactors are really important because we know that people who are ill or have taken certain drugs, medications, alcohol, they've exercised, or just maybe stressed, all of this impacts on the immune system and can cause more severe reactions. Reproducibility on repeat exposures is also really important. Has it just happened once or multiple times? Duration of symptoms, when did they start and how long they lasted for? Did anything help in terms of antihistamines perhaps, or if somebody has an EpiPen, was it used or not, and whether it helped or not? So all of this information is really, really important. So the big eight, so 90% of all food allergies are due to this big offenders, so the big eight. There is some age dependency in food allergy that we see. So milk, egg, soy, and wheat are much more common allergies in infancy and childhood. If peanut and tree nut allergy is diagnosed in the childhood, it's much more likely to be due to the type 1 IgE-mediated allergy. However, if you start to get reactions to peanuts and tree nuts later in adolescence or in adulthood, these are more likely down to the pollen food syndrome, where there is a crossover between pollens and specific foods because the protein are very similar. So if the reactions to fruit and veg are more severe, we can also suspect something called lipid transfer protein allergy, so LTP allergy. Usually it happens to the cooked fruit and vegetables, as opposed to pollen syndrome, which usually happens to the raw. That's why it's important to gather that as part of the dietary history. Fish allergy is much more common in children, and shellfish allergy is much more prevalent in adults. You can actually develop shellfish allergy even if you've been managing it with no problems before. And ultimately, you can be allergic to any food that contains protein. So how do we diagnose with food allergy diagnostic tests? So as you can see from this slide, there is skin prick test right at the top. There is blood-specific IgE tests or immunocap tests, and also component resolve diagnostics. So on this slide, you can see a picture of the peanut and just some of the components of that peanut that people can be allergic to. And this particular test can really be helpful in pollen food syndrome, for example, to distinguish whether the person is more is sensitized to the pollens to start with, and they're reacting to peanuts. So this test in particular checks for components of that particular food. You'll need a qualified allergy specialist to interpret this test because it's not always as black and white as allergic, non-allergic. Because as I've mentioned, some people are just sensitized to foods and never react to foods. So this test can actually pick up on that sensitization rather than food allergy. So in terms of the dietary management, It's a balancing act. You can see that there are a lot of things that you need to consider. So food avoidance remains the primary method of management of the food allergy. And you can see that on a scale of allergy diagnosis, you want to make sure that this is a correct diagnosis. You want to look at the age and the number of foods involved. Is it a child who is still growing? Is it an adult with added comorbidities, for example? What kind of nutrients are really important for this particular person? Accuracy of history and allergy tests. I mean, what kind of allergy tests that person's had? As I mentioned, non-IG allergies would not come up on tests, but the person may be still experiencing symptoms. So alternative investigations may be needed. Is it sensitization versus allergy? Is that person just sensitive to that particular food, but not experiencing any allergic reactions? And factors to consider. You're looking at nutritional intake and requirements. You're looking at their diet. You're looking at environmental, cultural beliefs, health and diversity of the exclusion diets, because by their nature, these diets are very restrictive. So they can lead to a lot of nutritional deficiencies. And we know that most adverse reactions to food are patient-reported. So it's really, really important to get the right diagnosis and to go and see the allergist or your primary care physician or general practitioner for the referral to the allergy service if allergy is suspected. We know that extended dietary exclusions also can lead to the loss of tolerance. This is particularly important if you've already been sensitized to that food or you have eczema. From research, we know that this can happen in as little as 7 days, but most of the research indicates that it could be just weeks and months. So if you've excluded the food for several months, you can actually develop allergy to it. The perfect balance between correct diagnosis and management takes into account all of these factors to really minimize the effect on quality of life of these people. So this slide just to illustrate some of the nutritional considerations. So if you are excluding one food from the group or a whole group of products, you can see that some of the nutrients found in those groups, they need to be replaced with something else. My clinical practice shows that people just exclude those foods and do not replace with anything. This is really dangerous. With respect to EDS, for example, there are some secondary complications that can arise, in terms of the bone and ligament health. So you may want to consider those nutrients. If you're excluding dairy, for example, where you're getting the calcium and other micronutrients that are essential for bone health. So you can see this slide really illustrates the issue that some people face when they're on exclusion diets, especially if it's multiple exclusion diets. So just to touch on why is it extra important in Ehlers-Danlos syndromes, we know that Ehlers-Danlos results from the connective tissue defect. So those type of connective tissue proteins are important in the structure of the skin, the ligaments, the muscles, the gut. They kind of form like a scaffold around the gut and hold it all together. This defect results in that structure being too fragile and lax. So it can lead to a lot of symptoms, even without specific foods, without specific allergies and intolerances. However, we do know that food allergies and intolerances are common in this population. We know that disorders of the gut-brain interaction, such as functional dyspepsia or IBS, are also prevalent. And we know that dysautonomia can have a huge impact on gut symptoms because of the role of the autonomic nervous system in gut motility and regulation of digestion. We know that primary immunodeficiencies and mast cell disorders are very common, and those cells are also involved in allergies. And eating disorders and disordered eating is also prevalent in EDS, especially amongst women. So when you can appreciate how incorrect diagnosis can also lead to unnecessary exclusions, unhealthy eating behaviors, low quality of life, and potentially actually loss of tolerance and acquisition of certain food allergies that you've never had before. It's really important to get a multidisciplinary approach where you've got the gastroenterologist, allergy team if required, if allergy diagnoses are made, nutritional professionals, psychology, psychiatry, pain management, and neurology to form an individualized plan of nutritional management. So in conclusion, I hope you could see that food allergy and food intolerances are completely different things, but they are used interchangeably and can lead to a lot of confusion. They do require detective work by a qualified allergy or gastro specialist to identify triggers that can potentially cause the symptoms, so appropriate tests can be completed. The 3R method remains the best way of diagnosing food intolerance. If you've taken the food out and your symptoms continue, please bring it back. That food is not to blame. Allergy tests in isolation do not diagnose food allergy. We do need an allergy-focused history, which is a cornerstone of diagnosis. Incorrect diagnosis can lead to inappropriate dietary exclusions, nutritional deficiencies, low quality of life, and actually more allergies. So do work with a qualified registered nutritional professionals to begin with, so they can help you to identify those triggers and potentially initiate appropriate referrals. Thank you for listening.